All right. Hello, everyone. Good evening. Uh, Good evening, everyone. So just let me know in the comment section if my audio is good. So there might be a slight audio video lag. Hello, Shivani. Good evening. All right. So let's start today's session. Now, before I start today's session, let me tell you something. This session is mainly meant for students preparing for the FMGE exam. And in today's session, what we are going to do is we are going to discuss the most important or high yield questions leading to the exam. So by high yield questions, I do not mean very tough questions. I mean the questions with the highest probability of being asked in your FMGE exam. And let me tell all my dear students that leading to the exam, there is no need to panic. Medicine is a vast subject. Accept it like that. So whatever is most important, most high yielding, just focus on that in the days leading to your exam. And do not worry too much regarding portions you have not covered. Okay. So Aditya, Naveen, Harman, Shivani, Gautam. Okay, so everyone, good evening. So let's start. Slight audio video lag will be there, slightly raining here, but I hope you can adjust with that. It's just a 1 or 2 second lag, that's it. Now let me start off with the questions. Well, in the next 2.5 hours, we are going to discuss the medicine questions. And what I expect from you is, rather than passively listening to the lectures, please be actively involved. You can type your answers in the comment section, because this is the time where you, as a student preparing for the exam, is supposed to have confidence. And even if you go wrong at a few places here while we are discussing the questions, that's perfectly okay. Probably you might get the same question in your exam and you can get that right there. Okay. So no need to panic, a friendly discussion of the questions, but be actively involved. Have a book with you, and whatever points that has not been covered in the lectures, please write it down. Okay. All right. So let's get started with the first question. Okay. All right. So the first question is regarding a 50-year-old male. He was admitted in the ICU. Okay. And why was he admitted? He was admitted following a head injury. Now, following this head injury, he has developed an electrolyte abnormality, that is hyponatremia. Okay, he has developed hyponatremia. And you are given additional lab values like the serum osmolality, which comes to around 272, and a urine sodium of 45 milliequivalents per liter. You are also given the data that the urine output is normal and the patient is clinically euvolemic. What is the diagnosis? Is it syndrome of inappropriate ADH secretion, cerebral salt wasting, septic shock, or central diabetes insipidus? At the outset, let me remind you that this is a very, very important topic. You will be asked questions either based on syndrome of inappropriate ADH secretion, cerebral salt wasting, or diabetes insipidus. So expect this question. And see, this is a very simple question. Now, what is your answer in the comment section? I see many of you rightly giving the answer. Excellent. So the background history is that of a 50-year-old male with a head injury. Okay, there is a head injury. And what is the electrolyte abnormality? The electrolyte abnormality is hyponatremia. Okay, is hyponatremia, right? Now tell me, what about the other lab values that are given in the question? What about serum osmolality? Okay, what about serum osmolality? Is it normal, high or low? And what about urine sodium? Urine sodium. Tell me. So serum osmolality, we know the value, the normal value of serum osmolality comes to around 275 to 290, 295. So that is the range of normal serum osmolality. So obviously in this question, serum osmolality is decreased. And urine sodium is 45, which means there is increased urinary excretion of sodium. However, the urine output is normal and the patient is clinically euvolemic. Now, in the setting of a low serum osmolality, hyponatremia with increased urinary sodium and patient being clinically euvolemic, what is going to be the diagnosis? The diagnosis is that of a syndrome of inappropriate ADH secretion. Okay, syndrome of inappropriate ADH secretion. Because we very well know that in this SIADH, where there is inappropriate ADH secretion to the osmolality, we know that patient is clinically euvolemic, but patient will be having hyponatremia, a low serum osmolality and increased urinary sodium. Now for your exam, let me just give you a very important high yield table. Now this is to differentiate three very closely related entities: SIADH, cerebral salt wasting, central diabetes insipidus, all of which were options in the question. Now in CR as well as cerebral salt wasting, in both of them the serum sodium will be actually low, whereas central diabetes insipidus you can have a high serum sodium. Now urine output is normal or low in case of CR, whereas in both cerebral salt wasting and central diabetes insipidus urine output will be high, okay, or you will have a polyuria. Now urine sodium will be high in case of SIADH, and even in cerebral salt wasting there is so much of urinary excretion of sodium and it will be very high, okay, very high, whereas in central diabetes insipidus it will be low. Now the clinical volume status, this is also very important. In case of syndrome of inappropriate ADH secretion, you will have normal volume status. Mostly the patient will be clinically euvolemic, mostly, okay. Whereas just think of a scenario of a cerebral salt wasting. There is so much of volume loss and the patient will be significantly dehydrated. So the intravascular volume status, it will be hypovolemic. And again, same as that with central diabetes insipidus. The vasopressin level in cerebral salt wasting and central diabetes insipidus will be low, whereas in syndrome of inappropriate ADH secretion will actually, in case of syndrome of inappropriate ADH secretion, vasopressin level will be high. So this is what you have got to study very well for your exam, because in this question it was a clinical scenario of SIADH. In another scenario, you might get another patient with hyponatremia who is having a urinary sodium excretion. There is increased urinary sodium excretion, but patient will be severely dehydrated. So then you will have to go for a cerebral salt wasting. Okay, I hope that is very clear. Let's move to the next question. So next question is again a favorite topic area. So I say area because majority of the exams you get a question from the topic of hypoproliferative anemias. Okay, so hypoproliferative anemias. Hypoproliferative anemias, you have heard this term in both your medicine and your pathology lectures, in which what is the most common hypoproliferative anemia? Iron deficiency anemia. And other than that, the next hypoproliferative anemia is the anemia of chronic disease. Now in majority of the exams you will get either a question from the iron deficiency anemia or anemia of chronic disease. So you can expect the question. Now what do you think is the answer for this? The true statement is being asked. The question is about anemia of chronic disease, not chronic kidney disease, chronic disease? Is it low hepcidin levels, a low serum ferritin, a decreased TIBC, or is it that iron stores are depleted? So you know that in anemia of chronic disease associated with certain inflammatory conditions or neoplasms, you will have alterations in the level of various inflammatory cytokines, which will have alteration in the level of hepcidin. All my dear students, first tell me what will happen to hepcidin levels in case of anemia of chronic disease. It will increase. Okay. So the first statement that is given is false, right? It is actually increase in the hepcidin levels. It's not low hepcidin, it is increased value of hepcidin. And hepcidin is very important, commonly asked MCQ, which is the most important regulator of the iron metabolism is hepcidin. It is a negative regulator. So hepcidin levels, when it increases, it will interfere with the mobilization of iron stores. Okay, and from the reticuloendothelial system, macrophages, the body won't be able to mobilize the iron. Okay, so that is the impact of a high hepcidin levels. Okay. Yes, and I can see in the comment section, Harman and Pankaj, they have rightly said hepcidin will be high. Now, what about the other values? Serum ferritin, TIBC, iron stores. Please remember this checklist on the iron studies. Okay, iron studies in anemia of chronic disease. Iron studies. Okay, so here the actual problem is in the mobilization of iron stores. So what will happen? You will have a normal or increased iron stores, and obviously when the iron stores increases, there is increase in the serum ferritin, but the mobilization is defective. So what will happen to serum iron? The serum iron will be low. The TIBC, very important, the TIBC, total iron binding capacity, it will be decreased, and there will be normal to reduced transferrin saturation. There will be normal to reduced transferrin saturation. These are the important parameters in iron studies that you should know. In addition to that, please also keep in mind that in anemia of chronic disease, you have increased red cell protoporphyrin, and like your iron deficiency anemia, this is also a hypoproliferative anemia. So you will have a hypoproliferative marrow. So this is very, very, very important. Okay. And dear students, this is a very important table I am showing you, because I told you iron deficiency may be asked. Sometimes you may get a question on anemia of chronic disease. I have seen in exams they are asking about B12 deficiency anemia also. You might be given a scenario of a strict vegetarian. Now whenever you have a strict vegetarian developing anemia, what anemia will you think of? B12 deficiency anemia, right? B12 deficiency anemia. Okay, so you have the various parameters: iron deficiency anemia, anemia of chronic disease, thalassemia, and sideroblastic anemia. Sideroblastic anemia has also been asked, but commonly asked ones: iron deficiency, anemia of chronic disease. You may get a thalassemia question also, like a patient having a chipmunk facies. Okay, you may get a scenario of a sickle cell anemia also. All these are important. So I'll just share this table also, those who are finding it tough to write in this short span. In the Telegram group of mine, I'll be putting this table also for you for your quick revision, because this is a very, very high yield table differentiating these anemias. Okay, all right. Shall we move on to the next question? Yes, all right. Okay. So the next question is about a 44-year-old female. and the patient is presenting with recurrent uveitis and scleritis. Okay, so the presentation is with a ophthalmological manifestation, but it's not that alone. The patient for the last 3 months is having a history of nasal discharge and shortness of breath. So it has got to do something with the respiratory system also. And on chest x-ray, what is the finding that is given? You are having cavitary finding. So lot of cavities are there in your lungs. The nasal mucosa is erythematous and reveals a perforation within the septum. Now this is very, very important. There is a very vital clue that is given. There is a nasal septal perforation. And the negative history that is given in the question is that there is no evidence of synovitis, rash or mononeuritis on examination. What is the likely diagnosis is the question. Now, what do you think? Pankaj, Niyas. So, what do you think is the answer? Is it polyarteritis nodosa, granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis and Takayasu arthritis? Well, it's very clear that all the options are related to vasculitis, okay, where you have inflammation of the vessel wall. So all are vasculitis. So what vasculitis is this? You see, you have the patient with nasal discharge and you see there is also perforation of the nasal septum. So one thing is quite clear, there is involvement of the upper respiratory tract. But is the disease process confined to the upper respiratory tract? No, because you can see in the question the chest x-ray is having multiple cavitary lesions. So you have your lower respiratory tract also being involved. Lower respiratory tract also being involved. So upper respiratory tract, lower respiratory tract is involved. Okay. Now along with that you see there are ophthalmological manifestations of uveitis and scleritis. Now there are so much of negative history is also given, no joint involvement, rash, mononeuritis they have given. So I can see Harman is saying eosinophilic granulomatosis with polyangiitis. Harman, can you tell me what is the other name of this entity, eosinophilic granulomatosis with polyangiitis? And also Pankaj, can you tell me what is this? Pankaj is saying the answer is B. So what is granulomatosis with polyangiitis? What is the other name? Well, granulomatosis with polyangiitis is also having another name, that is the Wegener's granulomatosis, whereas eosinophilic granulomatosis with polyangiitis is also known as Churg-Strauss syndrome. Okay, is also known as Churg-Strauss syndrome. Now, see, the vasculitis, which is having a significant predilection for your respiratory tract, okay, especially causing the nasal septal perforation, is option B, granulomatosis with polyangiitis, which is your Wegener's granulomatosis. But remember, even EGPA or eosinophilic granulomatosis with polyangiitis or the Churg-Strauss syndrome can also involve respiratory tract, but can someone tell me what sort of involvement of the respiratory tract is seen? It's mostly in the form of a refractory bronchial asthma. Okay, so a picture similar to that of bronchial asthma will be the respiratory manifestation of Churg-Strauss. Will be very similar to bronchial asthma. It's not a true bronchial asthma, but the manifestation will often be a bronchial asthma which is not responding to bronchodilators. Okay, all right. So the answer here is the option B. Let me just quickly tell you a couple of more important points. What is the characteristic deformity that you see in the nose in patients with Wegener's granulomatosis? Nasal septal perforation we have already discussed. In addition to that, very, very important, you are going to get something that is known as saddle nose deformity. You are going to get a saddle nose deformity. Okay. And On the left hand side, you can see this is the CT thorax, and the CT thorax, as you can see, is showing multiple lesions. And what is the peculiarity of these lesions? These are cavitary lesions. Remember in the question, in the chest X-ray also there were multiple cavitary lesions. And see, in case of Wegener's granulomatosis, what are the most important manifestations? Yes, you will have ENT manifestations, you have pulmonary involvement, and also, though not mentioned in the question, you can have renal involvement in the form of glomerulonephritis. Okay, so these are the important manifestations of Wegener's granulomatosis. All right. Okay. So this topic, okay, of the vasculitis, the various vasculitis, that is the large vessel vasculitis, that is Takayasu giant cell, medium vessel like Pan and Kawasaki, and the small vessel vasculitis, which includes both the immune complex mediated vasculitis as well as the ANCA mediated vasculitis. Both of them, this group is important. So definitely you will be getting one question from the topic of vasculitis. Very, very important. Okay. All right. Let's go to the next question. Now, before we go to the next question, a couple of tables again, which I will be sharing in the Telegram group. Let me also just share my number to you, so that after the session, if you want me to add to the Telegram group, just this is my number, Telegram number. So you can just ping me in Telegram. I'll share the link in this group. Okay. All right. And you see, this table is showing the difference between PAN, MPA. What is MPA? Microscopic polyangiitis, and GPA. The most important differences. Very, very important. We'll be sharing this table with you. And next is again differences between the eosinophilic granulomatosis with polyangiitis and GPA. And I have already told you, history of allergy or bronchial asthma is more common with what? Churg-Strauss syndrome. Okay, Churg-Strauss syndrome. Okay, all right. Now, let me see who's going to answer this. This is a question from nephrology. So, the image is showing a urine microscopic examination finding. So, urine microscopic examination finding in the form of either cast or crystals, both are important topics for your exam. And given below is a urine microscopic finding of a patient being admitted with to the nephrology ward. What is the likely diagnosis? So you have got to make the diagnosis based on the urine microscopic finding. Is it nephrotic syndrome, diabetic nephropathy, acute tubular necrosis, or is it renal cell carcinoma? Come on students, what's your opinion? Sunias, Disha, Gautam. So I can see so many of you rightly saying it as C. I completely agree with you. This is acute tubular necrosis. Even a similar question I shared yesterday in my Facebook page as well. Okay, so what is the examination finding? A very simple look at this image gives you an impression that looks very much muddy, okay, a muddy color. So the name of this particular cast is the muddy brown granular cast. Muddy brown granular cast. And whenever you have muddy brown granular cast, what is going to be the diagnosis? It is going to be a case of acute tubular necrosis. It is going to be a case of acute tubular necrosis. All right. Now, next question. You've got to be a bit smart here, because I know often students have a confusion between two options in this question. Let's see this question. This is regarding a 30-year-old AIDS patient. Okay, so HIV is also an important topic. You can expect question. So the AIDS patient is presenting with fever, cough, and yellowish sputum. Okay, so it's a respiratory presentation. The examination is showing bronchial breath sounds, and whenever you have bronchial breath sounds on examination, What is the common clinical condition that is associated? It is often associated with a consolidation. Okay, a consolidation, that is a pneumonia. Okay, so examination is showing bronchial breath sounds and crepitations in the right infrascapular area, and X-ray is showing right lower lobe consolidation. Okay, so the CD4 count is 55. Obviously, it is reduced. What is the most common cause of this condition? So an AIDS patient with a pneumonia is the scenario here, and you are given a very low CD4 count. Is it strep pneumoniae, staph aureus, mycoplasma, or pneumocystis? What do you think is the answer? So Steve is saying D, pneumocystis. So I see that some are saying pneumocystis. Nuclear briefcase, you know, so I like the name, nuclear briefcase. So Shivani is saying A. So it's a toss up between option A and option D. So these are the two options students often confuse. But let me ask you one very simple question. In the scenario that is given, is the pneumonia a lobar pneumonia or a bronchopneumonia? Tell me, is it a lobar pneumonia or a bronchopneumonia? Bronchopneumonia. So lobar pneumonia will have a lobar consolidation. Bronchopneumonia will have all these patchy infiltrates bilaterally. So it is called a lobar pneumonia, right? It is a lobar, this one is a lobar consolidation. So why is there a lobar consolidation here? It's clearly mentioned. One is the examination finding as well as the X-ray. It is showing lobar consolidation. So see, for pneumocystis erovisi, actually the pronunciation is erovisi, though you read it as a gerovisi, the actual pronunciation is erovisi. Now pneumocystis erovisi will have a bronchopneumonia like presentation, whereas it is the pneumococcus which will have a lobar pneumonia presentation. So in this question, since it is a lobar pneumonia, the answer cannot be pneumocystis. I completely agree with the students who are also thinking of pneumocystis, because obviously pneumocystis is also common when the CD4 count goes low, but the presentation is that of a bronchopneumonia. Okay, so what is the answer here? The answer for this question is going to be Streptococcus pneumoniae. Okay, Streptococcus pneumoniae. Okay, all right, let's go to the next question. Well, this is a very simple question, but this has been asked previously in the national board exams as well as one of the INI CET exam. Well, this is very simple, but it is basic, so you have got to know this. What is the gauge of the cannula shown below? What is the gauge of the cannula? 14, 16, 18, 20. Pankaj, Hussain, Dr. Maiman. All right, very good. I see Heyman, Harman and Sunil. Yeah, many of you rightly answering. So this is 18 gauge. Okay, 18 gauge. So the cannula as well as the gauges are also important. Now see, the grey cannula is 16 gauge, green 18, pink 20, blue 22, yellow 24, orange 14. So all these are also important. Okay. Now I am just telling you a scenario. If you have got a patient, you know, who presents in a after say a postpartum hemorrhage, significant loss, you want to give fluids as well as blood. Which cannula will you prefer? Is it a grey cannula, green cannula, pink cannula or a blue cannula? What will you prefer? So see, in such scenarios where you want to have a quick replenishment of large volume of fluids, you have to go for a grey cannula. Okay, a 16 gauge grey cannula. Okay, Very, very important. Okay. All right. Next is a question. Again, a very simple one. Identify the cardiac chamber enlarged. Okay. Identify the cardiac chamber enlarged. Is it left atrium, left ventricle, right ventricle? And whatever is given in the ECG, well, it is that of two leads. One is lead 2 and the other one is lead V1. So just have a look at these leads and tell me what is it conveying to you. Have a look at these two leads and tell me what is it conveying to you. So I can see many of you going rightly with left atrium. So can you tell me why this is a left atrium? Absolutely right, you are. Now see, whenever you have lead 2 being given, lead 2 and lead V1 are two very important leads where you will assess the morphology of your P wave. Okay, you will assess the morphology of your P wave in these two leads. Now normally, I'm just talking of the normal scenario. Okay, normal scenario, your P wave will be a smooth dome shaped wave normally with a duration less than 120 millisecond and amplitude less than 2.5 millimeter. Now in majority of the leads, the P wave is going to be upright and the P wave is going to be negative in which lead? AVR, and a normal biphasic nature of the P wave is seen in lead V1. So you can see this is a biphasic nature in V1. Okay, so you can see two phases, the first one corresponding to the RA depolarization and the second one corresponding to the LA depolarization. Okay, so if you want to individually see the two components of the atrial depolarization, which lead will you go for? It's lead V1, because even in lead 2 you are just able to see a single P wave. It's a combined right and left atrial depolarization, but to appreciate both the components of the atrial depolarization, you have got to focus on lead V1. Now what is given here is, see, do you think the P wave that you see here, let me just mark the P wave for you. Do you think the P wave is normal in morphology? Okay, do you think it is normal in morphology? You see the P wave here also. You see the second component of the P wave. Do you think it is normal in morphology? No. So Harman is saying there is a notch, a double bump in the P wave. So you can see there is a notch in the P wave. So there is a wide and notched P wave, right? Wide and notched P wave. So Harman, will you agree with me when I say that the duration of P wave is increased with a notch between? And what is the notch? It is between the components of right atrial and left atrial depolarization. Now which depolarization happens first? It is the right atrial depolarization that happens first. Now let me just show you two scenarios. Okay, so this is scenario 1 and this is scenario 2. So scenario 2 is just what we saw now. You are having a wide increased duration of the P wave with notching. Okay, but what is the change that you are seeing in the scenario 1? Are you seeing increase in the duration or the amplitude? Tell me, increase in the duration or amplitude. Let me see, you know, if you are able to get this right. Okay, so the scenario 1, you are seeing there is an increase in the amplitude of the P wave. So the amplitude goes above 2.5 millimeter. So here in case of case 2, it is a duration that goes more than 120 milliseconds. What will you call the first scenario? The first scenario is called a P pulmonale. Okay, it is called what? P pulmonale. And the second scenario is called a P mitral. Okay, so P pulmonale is suggestive of a RA overload, whereas P mitral is suggestive of a LA, left atrial overload. Right? So coming back to this question, here you are seeing that there is LA overload. The answer is left atrium. This is again a table just to summarize the changes in lead 2 and V1 in normal scenario, right atrial enlargement, left atrial enlargement, and obviously in certain conditions where you get both right atrial and left atrial enlargement, often happens in various multivalvular heart disease with a congestive cardiac failure. Okay, so that is very, very, very important. Okay, now a lengthy question. Now, dear students, don't get scared if you get a few lengthy questions in your exam, because I know that at least for some of you, the very sight of a lengthy question might scare you. But often what happens is, it is often the longest question that gives you more number of clues. And a very simple strategy to solve these long stem clinical questions, the first thing is to read the last line first. Okay, because otherwise for long questions you will be just cramming up all these data, maybe unnecessary data. But let's try the same strategy here. So what is the question asking you? This is asking you regarding definitive management. So this is regarding some clinical scenario, and all what they want from you is how you are going to manage this condition. Now this is regarding a 32-year-old male who is having a hematologic malignancy, which is a acute promyelocytic leukemia. And tell me, dear students, acute promyelocytic leukemia means which type of AML? Which type of AML is the acute promyelocytic leukemia? AML M3. So he is in the hematology department for a induction phase of treatment. So which means the patient is diagnosed with AML M3. You are planning treatment for this patient. The patient is admitted in the hospital. But the day prior to the starting of treatment, the patient develops a very important symptom, that is a sudden onset breathlessness. Now, what are the other data that is given? You see, the examination of the patient shows cold, clammy extremities. Obviously, there is some hypoperfusion and the extremities are cold. Patient is having tachycardia and hypotension. BP is 70 millimeter systolic, and the patient is also having tachypnea. Now the auscultation is showing air entry equal bilaterally. The JVP was elevated. ECG is showing sinus tachycardia. And the blood pressure is remaining low in spite of rapid fluid replacement as well as starting inotropes. Inotropes are agents that will increase the cardiac contractility. After doing a quick bedside echo, the doctor on duty ordered an urgent CTPA, and the finding is shown in the image below. Now, this is a very simple scenario of a patient who has developed acute onset breathlessness. Remember, in the background you have a AML M3, which is a condition that is predisposing to thrombosis. You know that malignancies in general, and especially three malignancies, that is the acute promyelocytic leukemia, which is AML M3, pancreatic malignancies, and prostate malignancies. These three malignancies predispose to thrombosis. Okay, they predispose to what? Thrombosis, blood clot formation. So acute onset breathlessness in the setting of a clot formation, I know already you are thinking of pulmonary embolism. It should strike your mind as a reflex. But let's see what sort of pulmonary embolism is this. Patient is having tachypnea, tachycardia, hypotension, and remember, the hypotension is not responding to fluids and inotropes. That is significant hypotension. The patient is in shock, okay, and JVP is elevated. obviously the right side of the heart has failed. Auscultation is showing normal air entry bilaterally, which means there is no pulmonary edema. But the CTPA is actually shown. And what is the CTPA finding? Now let me see if my students are able to say that what is the CTPA finding. So Datta is asking, can polycythemia vera predispose to thrombosis? Yes, it can. So you can see here, I'll just show by arrow. Can you see this part? Let me just highlight it by a different color. Can you see this part here? Okay, the arrow pointing to this. What is this big structure? Okay, there is a clot. Okay, so there is a clot. It's not a small clot, it's a big clot. And what will you call such big clots? This is called a saddle thrombus. This is called what? This is called a saddle thrombus. So whenever you have a saddle thrombus that is blocking the pulmonary vasculature, you get a massive pulmonary embolism. Nias Ahmed, very good saddle thrombus. Okay. So what sort of pulmonary embolism is this? This is an acute massive pulmonary embolism. How did I say massive pulmonary embolism? Patient is in shock, hypotension. You are giving fluids, still the patient is in hypotension. So in the setting of an acute massive pulmonary embolism, you guys tell me what is going to be the treatment. And the treatment is, see, let us look at the option: aspirin, digoxin, RTPA, furosemide. Well, see, already the patient is in hypotension, and also when you in the air entry it is equal bilaterally, so there is no pulmonary edema. So whenever there is no pulmonary edema, do you think furosemide has any role? No role at all. Okay, so don't think that any case of breathlessness you can give furosemide. No. Now any role for digoxin? Well, you have already given that in spite of starting inotropes, there is no role, no improvement. So there is no role of inotropes. So there is no role of aspirin in the immediate stage. But what you want to do right now is that since you have a big clot, you are going to go for a revascularization strategy. Now this term, revascularization strategy, is something that you will use in many scenarios. One is a pulmonary embolism, then you have myocardial infarction, then you have stroke. So in all these scenarios, when you have blood clots and when you want to lyse the blood clot, you go for a revascularization strategy. So what is going to be the revascularization strategy here? It is going to be RTPA. What is RTPA? Recombinant tissue plasminogen activator. Okay. All right. So recombinant tissue plasminogen activator, setting of massive pulmonary embolism. This is very, very crucial. Okay. All right. Now this is just a table to deal with the case of a pulmonary embolism with hemodynamic instability. Now this term is very important because only if there is a significant hemodynamic instability you will go for RTPA. So otherwise, if it is a pulmonary embolism without hemodynamic instability, can somebody tell me what are you going to manage the patient with? You are going to manage the patient with, good, you are going to manage the patient with heparin, anticoagulation. Even in pulmonary embolism, you will give the patient heparin, but what is going to be life-saving is going to be RTPA. So whenever you have a pulmonary embolism with hemodynamic instability, well, you have to go for recombinant tissue plasminogen activator. Okay, so this is the table I have discussed in my lectures of the DocTutorials app as well, the same table. Okay, all right. Let me discuss the next question with you. Okay, all right. So Dr. Maiman is asking about the PDF. What I'll do is those important tables I'll share in my Telegram group. So after the class, just join my Telegram group. Those important tables I'll be sharing. Okay, and I just want to share one more thing with all dear students. Um, See, especially in the days leading to the exam, I've told you this once before at the beginning of session, but let me tell you again. Please trust your notes that you have prepared during your preparation and practice these questions. I know that, when I take classes for FMG students, I've seen these students sometimes going after very tough questions and then, you getting demoralized. Please understand, yes, there will be a few questions in your exam which are tough. For sure there will be. But dear students, the rank deciding questions are not the mark deciding, or what is going to decide your selection is not going to be the very tough questions. If you answer the easy and the moderate ones, you're done. That magic 150 you will cross. But what happens is when you become too anxious of all these tough questions, in the actual exam you end up losing simple questions as well. Okay, come back to this question. Patient presented with anemia, bone pain and hepatosplenomegaly. Bone marrow finding is shown. What is the diagnosis? In fact, they have given, rather than giving you the disease diagnosis, the enzyme deficiency is being asked. So you can slightly revise the question to enzyme deficiency. Okay, what is the enzyme deficiency? Now tell me, what is the enzyme deficiency? As you can clearly see in the bone marrow finding, let me just show you the arrows. So are you able to see the fibrillary appearance or the crumpled tissue paper appearance? Okay, are you able to see the crumpled tissue paper appearance? Okay, so this is crumpled tissue paper appearance. So this appearance is classically associated with which condition? Is associated with Gaucher disease, and Gaucher disease can present with anemia, bone pain and organomegaly. So whenever you have anemia, bone pain, organomegaly and crumpled tissue paper appearance, bone marrow finding, so this is Gaucher's disease. And what is the enzyme deficiency? It is glucocerebrosidase. It is glucocerebrosidase. And as Aditya Panchal is rightly saying, this is a NEET question. This question was asked in NEET, and not just in NEET. In the recently concluded INI-CET exam also, the crumpled tissue paper question came. So even in FMG they have asked it. So this is a high yield topic, high yield question. This is a high chance question. Okay, very important. All right, let's go to the next question. Now, next question. This is an interesting question. Let me see how many get this right. First of all, you have got to make a diagnosis in this question, and that will fetch you the answer also. So this is regarding a 40-year-old male, and he is a chronic alcoholic and he is presented with abdominal distension and pedal edema. He is having reduced urine output for the past 2 weeks. On examination, he is having jaundice and serum creatinine is 2.6. What is the next step in the management? Okay. So what are the key points here? Chronic alcoholic, okay, and it's a recent onset of abdominal distension and pedal edema. And for the past 2 weeks, there is a decreased urine output. Okay, there is a reduced urine output. So in this chronic alcoholic patient, in addition to his GI problem, abdominal distension, he is also having a reduced urine output. Examination is having jaundice, but you can see there is a increase in the serum creatinine value. So what is the next step in management? So first of all, dear students, Harshida, Salim, Niaz, Jahangir, most of you have said it right. But first, can you tell me what is the diagnosis? What is the diagnosis in this case? What is the diagnosis in this case? Patient with a liver disease. Obviously, he is having liver disease. He is having jaundice, abdominal distension. So probably he is having an ascites, he is probably having a liver cirrhosis, but now he is having a renal involvement. And Jahangir Sheikh, excellent answer, Dr. Jahangir. So this is a scenario of HRS. What is HRS? This is hepatorenal syndrome. Hepatorenal syndrome. And what is this hepatorenal syndrome? It is a form of functional renal failure. What do I mean by a functional renal failure? The primary problem is not within the kidney. It is a hepatic problem which causes a functional renal failure, which means there is no structural damage with the kidney. And there are two types of hepatorenal syndrome, type 1 and type 2. Jahangir, can you tell me which is the more aggressive one, the rapidly evolving one? Is it type 1 or type 2? It is the type 1 which is more rapidly evolving. So type 1 hepatorenal syndrome is more rapidly evolving. So in hepatorenal syndrome, out of these options, well, we give a combination of albumin and also octreotide. Okay. So you are, yeah, absolutely right, Datta, due to the splanchnic vasodilatation. So you are giving vasopressors and also albumin, which is why you are giving octreotide plus albumin. And as many of you are saying in the comment section, type 1 is the acute one, right? So octreotide plus albumin. And also another drug that you can give is midodrine. Okay, midodrine is another drug that you can give, but it's not there in the option. But let me just slightly twist the question for you. Had the question being, what is the best step? Okay, forget about this option. What is the best step in the management? What option will you be looking for? What is the best step in the management? What option will you be looking for? The answer is going to be yes, very good, liver transplantation. Okay, liver transplantation. So the definitive treatment for hepatorenal syndrome, best treatment is the liver transplantation. But in this, the next line of management is going to be octreotide plus albumin. Okay, very good. Pragya, Datta, Niyas, all of you have rightly said. Yeah. So, what about a question from COVID-19? What is the mechanism of action of this antibody cocktail, that is casirivimab, imdevimab antibody cocktail in COVID-19? Is it targeting the IL-6 receptor? Is it targeting the IL-6 cytokine? Is it a JAK inhibitor, or is it targeting the spike glycoprotein? What do you think is the answer? Okay, so very good, very good. Seeing so many right answers. Okay, so this is targeting the receptor binding domain of the spike glycoprotein. Okay, so this anti-SARS-CoV-2 monoclonal antibodies are primarily targeting, very important question, targeting the receptor binding domain of the spike glycoprotein. And this is actually a combination cocktail. That is, total dose is 1200 milligram, 600 each, which is given IV or subcutaneously. Now, May 5, 2021, it actually received the emergency use authorization. Time to resolution of symptoms by 4 days, but action is very, very important. Okay, all right. Now, next question. See, next question is based on a scale. I have seen that in majority of the exams, there usually is one question based on a scoring system. So, the question can either be based on the ABCD2 scoring system of TIA, maybe the Curb 65 scoring system of pneumonia, or you can have a chat 2 DS2 VASC scoring system, that is on the use of anticoagulation in non-valvular AF. So there might be a question, okay. So these questions are expected, and commonly asked one is with respect to ABCD2. And you know, tell me guys, what is the utility of the ABCD2 scale? This is used for prognostication of transient ischemic attack. Prognostication of TIA. Prognostication of TIA. Okay, prognostication of TIA. Now, in this scoring system, maximum points is for what? Is it for the age more greater than or equal to 60 years, BP greater than or equal to 140? Steve is saying A, age. Jahangir, Pragya, Gautam. Aditya is doubting, is it B? Well, the correct answer for this, let's see. So this is ABCD2, A for age more than 60 years, more than or equal to 60 years. B is systolic blood pressure more than or equal to 140 or diastolic blood pressure more than or equal to 90. C is for the clinical symptoms and D is for duration. Well, A and B is 1 point each. Even the ABCD2, which means there are 2 Ds, the second D is also 1 point. But let's look C and the first D, clinical symptoms. If patient is having speech problem alone without weakness, what does that mean? Patients with stroke having a speech problem alone, just a Broca's aphasia, okay, no weakness. So speech problem alone, 1, okay. Whereas if the patient is having, very important, a weakness, then you will have 2 points, okay. What if the patient has both weakness and speech problem? Again 2 points, the maximum one. And duration more than or equal to 60 minutes is 2 and 10 to 59 minutes is 1. So here in this question, it's very obvious that unilateral weakness will have 2 points, okay. All right, okay. So Disha, whatever I have said now, these are the important scoring systems. Rarely, you know, they have asked about scoring system in subarachnoid hemorrhage, which is the Hunt-Hess scoring system. And rarely they have asked about the ICH scoring system. But I have not seen these two being asked in the FMGE exam. So in this last minute, I won't say that you have got to go through all the scoring system. Okay. All right. Fine. Let's go to the next question. Next is again a question from hematology. So hematology, blood grouping, cross matching, transfusion, all these related topics are very important. You will get some or the other questions from this topic, okay, that is either from this blood grouping, cross matching or the transfusion. So this is a slightly tougher question from transfusion medicine. So the question is this: transfusion associated lung injury, also known as TRALI, transfusion associated lung injury, can be caused by transfusion of red cells, plasma, platelets, all the above. What do you think is the answer? Okay, what do you think is the answer? Well, I'll tell you, transfusion associated acute lung injury is a condition where a patient can have an acute hypoxia as a result of a non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema. Non-cardiogenic pulmonary edema means the pulmonary edema is not primarily due to a heart failure. So this occurs with the transfusion of certain components in blood, especially the plasma. Very, very important. The TRALI is most commonly associated with transfusion of plasma. But as always in any entrance exam, please read the question carefully. They have just asked, they have not asked you it is most commonly associated. They have just asked you a plain straight question. The TRALI is caused by transfusion of red cells, plasma, platelets, all the above? Well, the answer here is all the above, because though it is associated more commonly with the transfusion of plasma components, it can also be a part of transfusion of red cells and platelets as well. So the answer is going to be all the above. Okay, all right. Now again, a very simple question. Now the question that I'm giving you now, this is a very relatively simple question, but I'll be showing you a table subsequently. That table is also very, very important. This is a very simple question. You tell me which of the following serologic marker is present in the window period of hepatitis B infection. Is it HBsAg, anti-HBs, anti-HBc, or HBeAg? Okay. Yes, what is it? Well, you see this, in fact, in the DocTutorials app also, there is a separate module on the serologic markers of hepatitis B, which is very, very, very important, and this figure especially. Now you see here, the earliest biomarker to appear, the earliest biomarker is the HBsAg, and you can see that there is a particular phase where the HBsAg is disappearing and the anti-HBs is appearing. So in this, there will be a small phase, okay, in this particular phase where HBsAg has disappeared, anti-HBs has not appeared. So this particular phase, you will call it the window period. So when you have this particular phase, there is one biomarker that can be detected, and what is that biomarker? It is going to be anti-HBc. This is very, very important. Now this is a common question that you are going to get in the serologic markers of hepatitis B. Okay, so you see here, Akram is saying answer A. No, Akram. See, window period per se itself means that your HBsAg has disappeared. Okay, HBsAg has disappeared. Okay, so yeah, I can see Rajeev Dhawan sir. Hello sir. Thank you, thanks a lot. Okay, so yeah, so in this period or the window period, the anti-HBc is the biomarker that is demonstrable. So this is very important. Let me also make one point clear to you. Window period. So very rarely only you encounter the window period now because of the increased sensitivity of the lab assays. Okay. Yes, Harman, anti-HBs is protective. Absolutely right. Rajneesh, hello. Now this question, okay, this question is very, very important. I'll share this table with you in the Telegram group as well. So they are commonly asking you questions based on the serologic patterns of hepatitis B. I have discussed this in detail in the DocTutorials app, but in the exam you will be given a scenario with the various parameters like HBsAg, anti-HBs, anti-HBc, HBeAg or anti-HBe, and you will be asked to comment on what phase of the disease the patient is in. So depending upon the biomarkers that are given in the question, you are supposed to make the comment. Okay, it's a simple one. Okay, all right, fine. Now next question. Now this question, a similar question also came in the INI-CT exam, and pharmacology question related to this has been asked previously in the FMGE as well. Now let's see this question here. So this is regarding a patient with a persecutory delusions. So he is feeling that somebody is trying to harm him, okay, and third person auditory hallucination, and he is diagnosed with schizophrenia. And once the diagnosis was made, the psychiatrist has prescribed him risperidone. Tell me, what is risperidone? It is an antipsychotic. Okay, it is a antipsychotic. So he was prescribed 2.5 milligram of risperidone, and next day he came to the emergency department with a persistent upward gaze. So his eyes had a persistent upward gaze. So it's like, he's constantly looking up and he is not able to look down. So he comes to the emergency department. The doctor sees he is persistently having an upward gaze. Now this is there for some hours. So what is the next step of management? Is it injection lorazepam, or reassuring the patient, injection phenytoin or injection promethazine? Well, this question is a bit tricky but a very simple one. Always remember, antipsychotics, I'm sure pharmacology faculty, Nilesh sir, definitely sir would have taught you regarding the adverse effects of the antipsychotics. So sir would have discussed regarding the dopamine blockade as well. Okay, so the various side effects. And see what happens in the antipsychotics. Well, long-term intake of antipsychotics, because it blocks these dopamine receptors, it can result in Parkinsonism. Okay, so we often come across patients with antipsychotics eventually developing drug-induced Parkinsonism. But remember, in this scenario that is given in this question, this is not a long-term side effect that is being asked. The patient was just prescribed on an antipsychotic the next day. So it is an acute adverse effect. And this adverse effect, where you have persistent upward deviation of the eyes, you call it by the name oculogyric crisis. And this oculogyric crisis is a form of acute dystonia. So what I meant to say, children, is that when you give antipsychotic, long-term intake, side effect, Parkinsonism. But there sometimes can be an acute adverse effect. And what is that acute adverse effect? It can be dystonia. And dystonia can be in various forms. One is a persistent upward deviation of eyeballs. You call it oculogyric crisis. There are other crises as well, like acute dystonic crisis, like a buccolingual crisis. Okay, what is it? You can also have a buccolingual crisis, where the dystonia will be in the oral cavity and the tongue. Okay, but this one is an oculogyric crisis. So, okay, we have understood this is an acute dystonic reaction. So, yeah, what this is, so Harman is asking, so what is the antidote? So obviously that is what exactly what Harman asked is what the examiner also wants to know. What is the treatment for this? Now, you will agree with me when I say that in your body there is a dopamine cholinergic balance. Yes, there is a dopamine cholinergic balance. I have taught you this in the neurology modules in the app as well. So in Parkinson's disease, this balance is being disturbed. And similarly, here also, what happens is this balance is being disturbed, and you have to bring down the cholinergic activity as well. And for that, you have to give the patient anticholinergic. Okay, you have to give the patient anticholinergic. Now, see, out of all these options that are given, is there any anticholinergic? Tell me, is there any anticholinergic? Well, option D is promethazine. Well, this is an antihistamine, but remember, though this is an antihistamine which is having anticholinergic property as well. Okay, because of which the answer to this question is going to be D, and you are going to give the patient injection promethazine. Okay, all right. Now, next question. The false statement about remdesivir in COVID-19. Options: indicated only in moderate to severe disease, inhibits RNA dependent RNA polymerase, should be given only in patients with 10 days after onset of symptoms. It is an adenosine nucleotide prodrug. What is going to be the answer here? So here again, you clearly have to know about the role of remdesivir. So remember, in the initial part of the COVID-19 pandemic, there was so much of a discussion about remdesivir, but later we understood only in selected scenarios you have got to give remdesivir. So see, remdesivir is indicated in moderate to severe disease is a correct statement. There is no need to give remdesivir in a mild case. It inhibits RNA dependent RNA polymerase is right. It is an adenosine nucleotide prodrug is right. But the third option, it should be given in patients 10 days after onset of symptoms is wrong. And does somebody want to help me correct the option? If I want to make this a correct option, what am I going to do? It is within 10 days. So within 10 days of onset of symptoms, you have got to give remdesivir. Okay, within 10 days. Okay, so that is going to be C. Okay, all right. Now, the next question is on pulmonology. It's a very simple question. It's a basic question. I won't say it is a very simple question. It is a basic question, provided you know the physiology well. Okay. All right. So the question is DLCO. What is DLCO? Diffusion capacity of carbon monoxide is decreased in all the following except pulmonary hemorrhage, ILD, emphysema or anemia. So what do you think? What do you think? What do you think is the answer? Well, see, DLCO depends mainly on the two factors. One is the integrity of the alveolo-capillary membrane, okay, and also the second one is the gas exchange area. So these two parameters are the ones on which DLCO will depend upon, and in these scenarios, ILD, emphysema and anemia, in all of them the DLCO will be decreased. But what is going to be the answer here? In pulmonary hemorrhage, where the DLCO will be increased. Mohammed Akram, excellent answer. Steve, Niaz, Pankaj, very good. Okay, so the answer is going to be A. And let me just give you a small table on the conditions associated with DLCO. One is emphysema. I told you DLCO depends on the gas exchange area as well. Interstitial lung disease, obviously whenever you have interstitial lung disease, you will have a disruption of the alveolo-capillary interstitium, right? Then about pulmonary vascular disease, left-sided heart disease, even anemia, all these conditions are characterized by a decreased DLCO. Okay, all right, all right. Okay, now next question. The next question, let me see how many get this right. This is again a question related to rheumatology. 23-year-old male complains of low back stiffness and early morning stiffness. Okay, so two complaints. One is low back stiffness and early morning stiffness for 30 minutes since 2 years. Now complains of bilateral heel pain. What is it? Bilateral heel pain. His eyes were always red looking. What is the most likely cause? Yes, Nancy Hussain, very good, excellent. So I know that all of you are very well prepared for your exam because you are promptly saying the answer correctly. See, whenever you have a male in this 20 to 30 years age group having a low backache, remember, see, low backache, that certainly roots out rheumatoid arthritis. Because rheumatoid arthritis, you tell me, is it a disease that primarily affects the axial skeleton or the appendicular skeleton? Axial means your spine and all. Appendicular is your limbs, upper and lower limbs. Okay. So tell me, it's predominantly what? The appendicular. But in the axial, it's only in the cervical, that is the atlantoaxial region, that you can have involvement. No way in rheumatoid arthritis somebody presents with low backache. So that is out. Okay. But see, he is having it for 2 years and there is bilateral heel pain. Now those who have correctly said the answer as A, ankylosing spondylitis, can you tell me that what is this bilateral heel pain? What is this bilateral heel pain? In this scenario, this is actually enthesitis. What is enthesitis? It is an inflammation at the region where a tendon gets attached to a bone. So that is called enthesitis. Okay. So there is enthesitis. Now you tell me, in spinal TB or disc prolapse, is there any reason why you should get enthesitis? There is no reason why you should get enthesitis. So that is also less likely. Now, there is another point that is given. His eyes were always red looking. So as I can see Niaz Ahmed rightly saying, it's because of the uveitis. So there is one additional MCQ that I am bringing here. In ankylosing spondylitis, what is the most common extra-articular manifestation? What is the most common extra-articular manifestation? It is actually uveitis, anterior uveitis. So the eyes were looking red. Why? Because of the uveitis. So the answer for this question is going to be ankylosing spondylitis. Pankaj, thank you. It's a pleasure to interact with all of you. Okay. I am in fact more happy that you are all my students. Okay. All right. Let's go to the next question. Now this is a question that integrates medicine and pharmacology, because you should expect such questions, because I have seen in the FMGE questions there are questions which integrate medicine and anatomy as well. We are having a couple of questions in that genre also, which will be discussed very soon. But see, this is a patient, 35-year-old patient. He is in the medical ICU for pneumonia. Okay. And since the culture yielded MRSA sensitive to vancomycin, he was started on vancomycin. Soon after the drug administration, he developed flushing, tachycardia, hypotension. Okay, what is the likely phenomenon? Is it MODS, multi-organ dysfunction syndrome, Redman syndrome, sepsis, staphylococcal scale syndrome? Now this is actually very simple. I can see many of you answering correctly, because whenever you give vancomycin already in the question. Now remember, dear students, in your FMG exam, at least five questions, even if you are not very sure about the question or the diagnosis, you will get some idea with common sense. So please have good presence of mind, have good common sense, because even if you are doubting, okay, sepsis also can bring in some rash, hypotension, tachycardia. So you can see in the image the patient is having rash, but can't it happen with sepsis? But look at this, in the question, it specifically mentioned soon after drug administration. So this is likely to be an acute complication after the drug. And patients who are treated with vancomycin, because if you give it rapidly, not all cases, if you give it rapidly, rapid IV infusion of vancomycin can bring in flushing, hypotension, tachycardia, which is known as Redman syndrome, and the answer is Redman syndrome. I'm very happy all of you are answering correctly. Answer is Redman syndrome. A very simple question, but I don't want you to miss out on this. At least one or two questions might come from nutrient deficiency. I say one or two because one examiner might put from the biochemistry perspective and another from medicine perspective. So what is a nutrient deficiency in this patient presenting with skin discoloration? You can see the examiner has made it very easy for you. I have made it very easy for you that the skin pigmentation is in the neck area, almost in the form of a necklace. This necklace-like skin pigmentation around the neck is called a Casals necklace. Okay, Casals necklace, and this is associated with a deficiency of niacin. So what is the condition that is associated? It is pellagra. So pellagra associated with niacin deficiency can have this. And remember about the 3 Ds. Can somebody tell me what are the 3 Ds of pellagra? It is diarrhea, dermatitis. So dermatitis can be in the form of skin pigmentation like a Casals necklace, and also dementia. Dementia. All right. Let's go to the next question. Now, the next question is a question that integrates medicine and anatomy. I have purposefully asked this question because this is the same question. This was asked 2 years back in NEET PG. Because I have seen some questions of NEET PG overlapping with FMGE with the latest patterns. Let's see this. Patient presented with bitemporal hemianopia. So the patient is having a ophthalmological presentation with a bitemporal hemianopia. On imaging, it was found that an arterial aneurysm, okay, so the problem is an arterial aneurysm pressing on the optic chiasma. What is the likely artery involved? So you have learned in the endocrinology lessons that I have taught you, whenever there is a pituitary adenoma, this can press on the optic chiasma and you can have bitemporal hemianopia, correct or not? Yes. But here the question is not about a pituitary enlargement, it is a vessel enlargement. Now you tell me which vessel enlargement can have this bitemporal hemianopia. Let's see. Yes, so you see here, look at this image. So this is the region of a ACOM aneurysm. What is ACOM aneurysm? Anterior communicating artery aneurysm. So let me just point the with the help of an arrow the aneurysm. Do you see this region with bulging? And you see, just adjacent to the the region of the optic nerve joining to form the optic chiasma. And what is the vessel that is adjacent? There is the anterior communicating artery, and when there is an aneurysm involving the anterior communicating artery, this can press on the optic chiasma. Let me add one more point to you. When you have a ACOM aneurysm, the aneurysm can progress in different directions. Okay, it can go anteriorly, inferiorly, posteriorly, and we call it projections. Okay, anterior projection, posterior projection, superior projection, inferior projection. And let me ask you a simple common sense question. Which projection can press on the optic chiasma? Just use your common sense. It has to go down. So it is going to be the inferior projection. So inferior projection, ACOM aneurysm will press on the optic chiasma, and you can have a bitemporal hemianopia, just like the defect that you see associated with the pituitary adenoma. Okay, I hope that is very clear for you. Next question. A patient stopped alcohol. So the answer to this question, simple one, it is the anterior communicating artery aneurysm. Okay. Patient stopped alcohol for 3 days and presented with irritability, disorientation, paranoid delusions, visual hallucinations and altered sensorium. What is the most likely diagnosis? Delirium tremens, Wernicke's encephalopathy, Korsakoff psychosis, hepatic encephalopathy. What do you think is the answer? What do you think is the answer? What do you think is the answer? So I can see many of you going for delirium tremens. Let me just ask you one question. Pankaj, Harman, Selva, let me ask you one question. Okay, you are saying a delirium tremens. Let me try to contradict you. How do you know this is not a hepatic encephalopathy that can also present with this irritability, confusion, disorientation? And how do you know it's not a Wernicke's encephalopathy? It is also associated with alcoholism. How do you know that? So, can you make that point a bit clear? Because if you are clear with that concept, then I am sure that you will get all questions related to alcoholism in your exam. Any alcohol related question, you have got to answer, because alcohol is supposed to be the national drink of the country. So any alcohol related question, you have got to answer that correctly. Okay. Yeah, Anjali, very good point. Selva has also said it. See, I have specifically said that the patient stopped alcohol for 3 days. So the current clinical presentation is after stopping alcohol for 3 days. So after stopping alcohol for 3 days, then the patient's symptoms started. Now, had it been Wernicke's encephalopathy, though the patient will have confusion, I know that you would also be knowing that there are other features associated with Wernicke's, like confusion, ophthalmoplegia, nystagmus and ataxia, yes, but all findings need not be present in the same patient. So even though patients with Wernicke's can present with confusion, since this 3 days is mentioned, because delirium tremens happens within 48 to 72 hours in a chronic alcoholic. Once he stops alcohol, suddenly stops alcohol, in the next 48 to 72 hours, he might develop all these symptoms of irritation, disorientation, paranoid delusions, hallucinations, which is called delirium tremens. Even in hepatic encephalopathy, there is no reason why there should be a specific mention of this 3 days, which is why the answer is going to be delirium tremens. Because I want you to carefully look at this, because in your exam sometimes you might get another scenario of a Wernicke's encephalopathy. So you should know, okay, which scenario will I go for this? Okay, all right. So that is also clear. Okay, right. Next question. It's again for endocrinology. In a patient with a subclinical hypothyroidism, what would be an indication for treatment? Now, what is a subclinical hypothyroidism? Subclinical hypothyroidism means the patient's TSH is elevated, so there is a biochemical abnormality, but there is no obvious symptom, which means the patient might have done a routine blood investigation for something else, and coincidentally he is found to have an elevated lab value of TSH. No, not much very obvious symptoms. So how to just decide on treatment? What do you think? Yes, the answer is going to be all the above, because if there is presence of anti-TPO antibody, then you should think of which condition. Tell me, which condition will you think of? You will think of Hashimoto. You will think of Hashimoto. You will have to treat a TSH value more than 12. Well, if it is in the range of 5 to 10, you will think, okay, no problem. But if the patient is not having much symptoms, if he is symptomatic, definitely you have got to treat. But it is 12, which means it is elevated. You have got to treat this. Even if the patient is not having symptoms, you have got to treat. Recent weight gain. So patient, because see, obviously with all our food habits, there are numerous other reasons why you should get obese. So just getting obese might not bring someone to the doctor, but still if on careful inquiry you find that there is a recent weight gain, that is also an indication for treatment. So this is all the above. Next, a favorite question. A 29-year-old athlete suddenly collapsed and died during a football game. Okay, So the scenario is that of a SCD or a sudden cardiac death. At autopsy, the following findings were seen on gross examination. He had a history of 2 similar deaths in the family previously. What is the most likely cause of death? Hypertrophic cardiomyopathy, rheumatic heart disease, coronary heart disease, dilated cardiomyopathy. What do you think is the answer? So I can see many of them going for A. A couple of you are going for option D. So majority are A. Okay, let me ask you one question. See, sudden cardiac death can occur in all these conditions, especially hypertrophic, you can have dilated, even coronary heart disease. Okay, these 3 are especially known to have sudden cardiac death. Rarely in rheumatic heart disease, suppose you get a dangerous arrhythmia, okay, like a MS patient developing a atrial fibrillation and subsequent death, that can happen. But something that is given in the history is there is a positive family history. So it is likely to be genetic. You cannot completely rule out coronary artery disease because you can have a family with multiple members affected by coronary artery disease, but most likely it is a genetic condition. So you are left with 2 options, hypertrophic and dilated. Now how did you identify this? The answer is A, hypertrophic. Now you look at the figure now. This is where the gross image is important. Now what is this part that I am highlighting in green? And tell me what is this part I am highlighting in red. So the part that I am highlighting in green is the portion of the IVS. What is IVS? Interventricular septum. Okay. Whereas the part that I have highlighted in red is the LV free wall, which is the left ventricular free wall. Now in case of hypertrophic cardiomyopathy, it's a hypertrophy that happens. So you have a bulky, thick ventricular myocardium, and often what happens in this condition is ASH. What is ASH? ASH, what is ASH? ASH is not Aishwarya Rai, but what is ASH here? Asymmetric septal hypertrophy. Okay, it is asymmetric septal hypertrophy, which means the hypertrophy that happens in hypertrophic cardiomyopathy is not a uniform hypertrophy. It's mostly in the region of IVS. You can also have hypertrophy in the LV free wall. Yes. So this gross image definitely, convinces you that the diagnosis is going to be a hypertrophic cardiomyopathy. Okay. All right. Next question. Now, next question is 60-year-old male presents with acute onset palpitations and chest tightness. Blood pressure was 130/80 millimeter mercury. ECG is shown. What is the initial management? Okay, initial management. Let me first for 30 seconds show you the ECG. Okay, so Chandrakant, regarding PDF, whatever are the important tables that I have shared with you, I will be sharing in my Telegram group. So you can join my Telegram group. Okay. So first of all, tell me what is the ECG finding? What is the ECG finding? So let's look at the options. Primary PCI, adenosine, DC cardioversion, amiodarone infusion. Yes. So what is the ECG finding? First of all, tell me about the heart rate. Is the heart rate normal? Is it tachycardia or bradycardia? So you can see that between say 2 R waves, you can say that almost it is 1.5 large squares. So 300 by 1.5 large squares. So it is heart rate is approximately coming to around 200. Okay, 200 per minute. Okay, 300 by number of large squares or 1500 by small squares. So heart rate is at least 200. Yes. So Niyas, it's more than 150 because you can see it's not, if it is 150 it has to be 2 large squares. It is not that much. So it is, heart rate is approximately 200. So it is a tachycardia. And Pankaj, is this a narrow complex or a broad complex tachycardia? Come on. Is it a broad complex or narrow complex? So any tachycardia, it's very important to look at the QRS morphology. So you can see that the QRS morphology is normal, which is why this is a narrow complex tachycardia. Okay, narrow complex tachycardia. And yes, I do accept the fact that if you look at the leads, the lateral leads especially, V5, V6, V4, V5, V6, there is some sort of ST depression. But let's try to see, if it is significant or not. We'll soon find out. But this is a narrow complex tachycardia. Now, in this narrow complex tachycardia, see what are the narrow complex tachycardias that you know of? You can have a sinus tachycardia, atrial fibrillation, atrial flutter, and the group of PSVTs or the paroxysmal supraventricular tachycardia. Now, if you look this ECG carefully, tell me, Dr. Benedict, Nisita, are you able to see P waves? Just tell me. Ajit Kumar, can you see P waves? Yes or no? Are you able to see P waves? Yes or no? You are not able to see P waves. Okay. Now, since you are not able to see P waves, you are sure on one thing. Is this sinus tachycardia? Tell me, is this sinus tachycardia or not? This is not going to be sinus, because had it been a sinus tachycardia, impulse originating from SA node, you would have had the P wave. Now, atrial fibrillation, again, P wave will be absent, but is this a case of a atrial fibrillation or not? Because obviously in atrial fibrillation also the P wave will be absent. But is this atrial fibrillation or not? It's not, because you tell me, is this a regular narrow complex tachycardia or an irregular narrow complex tachycardia? This is a regular narrow complex tachycardia. And tell me, atrial fibrillation, I agree this is atrial fibrillation is also a narrow complex tachycardia. It is also a narrow complex tachycardia without a P wave, but atrial fibrillation is irregular. Here it is regular. Okay. And for atrial flutter also you are not seeing any sawtooth P wave. Okay. So you are definitely going to think in lines of the paroxysmal supraventricular tachycardia. And when you have such PSVTs, what is going to be the first management here? Now tell me, is it going to be adenosine or DC cardioversion? Is it adenosine or DC cardioversion? Well, that is where the clinical history is important and the examination is important. Because clearly you can see that the blood pressure is 130/80, which means the patient is having no evidence of hemodynamic instability. No evidence of hemodynamic instability. So if there was hemodynamic instability, you would have gone for the DC cardioversion if the patient was in hypotension. But otherwise, how will you manage a case of PSVT or a paroxysmal supraventricular tachycardia? You will manage either by your vagal maneuvers. Okay, you will manage by your vagal maneuvers. Okay, or if not the vagal maneuvers, if it is not working by the vagal maneuvers, you will next go for IV adenosine, which is the answer here. Vagal maneuver is not given here, so adenosine is given. Only if it does not respond to adenosine will you go for, say, agents like a beta blocker or a calcium channel blocker. So the answer is going to be adenosine. It's not going to be amiodarone infusion, because amiodarone would have been the answer only if it was a broad complex tachycardia like a ventricular tachycardia. This is a narrow complex tachycardia. It's not DC cardioversion, I have already told you. Primary PCI, remember this is not a acute coronary event, because though there is ST depression, it is most likely a result of the tachycardia, because tachycardia per se can induce some ST depression. And just because you saw ST depression, don't think, okay, actually the ischemia is the problem. Ideally, you have got to look at the rhythm first. So this is a paroxysmal supraventricular tachycardia, and the answer is going to be adenosine. Okay, all right. Okay, let's go to the next question. Next question. 9-year-old boy presented with difficulty in climbing stairs and combing hair. On examination, a rash is present on the knuckles of hand and below the lower eyelids. What is the next diagnostic step? Tell me. What is the next diagnostic step? So, patient with a difficulty in climbing stairs and combing hair. Now, see, for combing hair, predominantly you need which muscle? Is it proximal or distal? Because though you are combing your hair with your hand, for combing, the proximal muscle should act. And similarly, if you have a difficulty in climbing stairs, that is also likely, to involve your proximal muscles. So would you agree with me when I say that this 9-year-old boy is having some proximal muscle weakness? Agree with me? Proximal muscle weakness. Now, so Akram is saying Gower's sign. Akram, you are right. Any patient with proximal muscle weakness can have Gower's sign, which is best elicited in the Duchenne muscular dystrophy. But here, it's not just Duchenne muscular dystrophy. What is the other extra examination finding that is there? You are able to see rashes on the knuckles of the hand and below the lower eyelids. And when you have such sort of rashes with proximal muscle weakness, okay, which is having either an acute or a subacute onset, you are thinking of an entity that is known as, let me see, Satya Prakash is saying myasthenia. Satya, I have not said anything about fatigability. And do you think, Satya, that in myasthenia you will have rashes? Because Satya is thinking of RNS, but rashes is not there. I completely agree with Satya on one aspect. You can have proximal weakness even in myasthenia. I agree with you, Satya. But rashes will not be there. So this is going to be, this is not Duchenne muscular dystrophy. Cutaneous manifestation with a proximal muscle weakness, acute to subacute onset. You are thinking of dermatomyositis, which is coming under the entity of inflammatory myopathies. Okay, coming under the entity of inflammatory myopathies. And repetitive nerve stimulation is out, because that is for myasthenia. RA factor, no way this is going to be rheumatoid arthritis. MRI cervical spine. See, cervical myelopathy can have a quadriparesis, but UMN weakness is mostly going to be distal weakness. This is specifically given a proximal weakness. And so MRI cervical spine is less. Now, when you have dermatomyositis, you tell me what will happen to the creatine kinase, okay? Your CPK levels, creatine phosphokinase, the levels will be elevated. So the next step will be, CK levels, which will show elevation, okay? Yeah, so that's right. So Satya, very good. Now you're right. You've got it right now. So I hope that is very clear for you. All right. All right. Okay. So just, I want all my children to go through these questions. Do share this, with this link with your FMGE friends as well. They will also be benefited, because these are the most high yield topics. I have selected only the most high yield, the repeatedly asked ones, because I did not want to just, bring in some very tough questions and discuss. Whatever is having highest probability for asking in questions, important clinical scenarios, some important questions with tables, some important image based questions, that is what I am discussing. Okay, so do share this with your FMGE friends. Okay, All right. And next question, which of the following is not a feature of extramedullary tumor? So this is talking of spinal cord findings, okay, not a feature of extramedullary tumor. Is it early corticospinal signs, root pain, abnormal CSF findings, sacral sparing? Now this is a purely conceptual question, okay. I have discussed this in detail in my lectures in the DocTutorials app, but let's try to see if you can answer this one. See, when you have an extramedullary tumor, so extramedullary means what? Medullary means, though the term medulla actually means, your medulla in the brainstem, but as far as spinal cord is concerned, it means a substance of spinal cord. So when you have a lesion that is within the substance of the spinal cord, okay, suppose you have a lesion within the substance of the spinal, this is central canal. So if there is a lesion within the substance of the spinal cord, you call it a intramedullary lesion, okay, which can be different type of lesions, okay. So that is called a intramedullary lesion. And any lesion outside is called a extramedullary lesion, outside the substance of spinal cord. Now extramedullary lesions can be of two types. That is, you have the dura mater, right? You have the dura mater. So you can have a lesion that is outside the substance of the spinal cord, but it is within the dura, which is called extramedullary. Why? Because it is outside the substance of spinal cord, but it is inside the dura, which is called extramedullary intradural. Okay. At the same time, you can have a lesion which is outside the substance of spinal cord as well as outside the dura. And what do you want to call it? Tell me, children. Extramedullary extradural. Extramedullary extradural. Now both these are actually extramedullary lesions. Okay. Now whenever you have extramedullary lesions, let me ask you one question. Okay. See, in the lamination of the spinal cord, you have the corticospinal tract, correct? So the corticospinal tract, it is going through the grey matter of the spinal cord or white matter? What do you think? Okay, is it going through the grey matter or the white matter of the spinal cord? Grey matter or white matter? So this is the corticospinal tract is a descending pathway, which is going through the white matter. And in the corticospinal tract that goes down, tell me the most medially located fibers, are they the cervical, thoracic, lumbar or sacral? I want you to answer this. The most medially located. So it goes in this order, CTLS from medial to lateral. The most medially located one is cervical. So tell me, when you have an extramedullary lesion, okay, which is outside here, and the lesion is slowly growing in size, the earliest involvement will be in the cervical or the sacral one. Which will be involved earlier? It will be the sacral one. So in case of an extramedullary tumor, you will have an early sacral involvement, whereas if it is an intramedullary tumor, it will be a late involvement of the sacral fibers, and it is an intramedullary tumor that will have a sacral sparing. Okay, intramedullary tumor will have a sacral sparing. Okay, now the other one, so the first option, the answer is going to be sacral sparing. It's not a feature of extramedullary, it is a feature of intramedullary. Let's see the other features. Early corticospinal signs, yes, it is a feature. You can have pressing on the white matter and you can have early corticospinal signs, true. Root pain, see, what is the commonest extramedullary lesion? I'm not talking of tumor, but lesion that you know of, disc. You will have a disc. So when you have a disc, what will happen is that the disc will, or a disc bulge or a disc prolapse will press on the nerve roots that are coming out. So that will result in a pain that is known as root pain, also known as radicular pain. Root pain or radicular pain. Okay, root pain or radicular pain. And so root pain or radicular pain, you tell me, is it likely with extramedullary or intramedullary? Intramedullary is within the substance of spinal cord. There is no way you are going to get root pain. It is the extramedullary that is going to press on the nerve roots. As, yeah, correct. As you are saying in the comment section, completely agree with you. Okay, all right. So that is also clear. Now, about abnormal CSF finding. Now tell me which one, extramedullary or intramedullary. You know that in the outside this the substance of the spinal cord, you have the coverings of the spinal cord, right? Covering the spinal cord, you have the pia mater. Outside the pia mater, you have the arachnoid, and then you have the dura mater, correct? Outside you have the dura mater. So in the subarachnoid space, what is there? You will have CSF, correct? Tell me, dear children, which sort of lesion is likely to press on the subarachnoid space more commonly? Is it going to be intramedullary or extramedullary? Pressing on the subarachnoid space. It is very obvious from the figure that this is going to be the extramedullary lesion. So the abnormal CSF finding which occurs because of the obstruction of CSF flow. And what abnormal CSF finding? Whenever you have blockage of the flow of CSF, the CSF abnormality that you are going to get is an increase in the CSF protein. Increase in the CSF protein. Okay. So the answer is going to be sacral sparing. And for all of you who want to have a table, sir, last few days before exam, we need a simple table to differentiate between these two lesions. This is what? Extramedullary and intramedullary. Radicular pain occurs in extramedullary. Intramedullary, you can have pain, but it is a funicular pain or a burning type of pain. The vertebral pain, commonly associated with pot spine or the disc, is common with the extramedullary and common with intramedullary. Sacral sensations are lost early. The lamination for the corticospinal tract, medial to lateral CTLS, holds the same with spinothalamic tract also, which is why sacral sensations are lost early in case of extramedullary, whereas sacral sparing occurs in intramedullary. Okay, sacral sparing occurs in intramedullary. Then dissociated sensory loss, it is present in case of intramedullary lesions. Paresthesias are ascending in case of extramedullary, obviously because lateral most are the sacral fibers, that is for the spinothalamic. So if you have an extramedullary lesion that slowly grows and presses on the spinothalamic tract, it is first going to have involvement of the sacral, then lumbar, then thoracic. So paresthesias will be ascending in extramedullary, descending in intramedullary. Early corticospinal tract involvement in case of extramedullary, late in case of intramedullary. Bladder involvement late in extramedullary. This is also a simple concept, that is the bladder fibers are located just around the central canal. So you see here, this one is the central canal which I am showing you in arrow. So if the bladder fibers are just around the central canal, tell me, is it going to be the intramedullary lesion or the extramedullary lesion that is likely to press on this central canal, region of central canal? Intramedullary. So bladder involvement will be early in case of intramedullary, late in case of extramedullary. CSF abnormality I have already told you. This is actually basic concept. Okay, so that's it. Okay, simple question. Next question, stamping gait is seen in, very important. Is it myopathy, foot drop, sensory ataxia or hemiplegia? What do you think? Stamping gait. See, stamping gait often happens when your foot is not able to feel the sensations. Okay, foot is not able to feel the sensations. So this often happens in case of sensory ataxia, which actually happens, sensory ataxia can happen either because of a large fiber neuropathy, which can happen in diabetes, or it can also happen in posterior column lesion. Okay, this will produce stamping gait. What about myopathy? What sort of gait? You will get a waddling gait. Okay, myopathy, you will get a waddling gait. Foot drop, you will get a high stepping gait. And hemiplegia, you will get a circumduction gait. Okay, all right. So gait abnormality, just a summary table. Festinant gait is seen in Parkinsonism, wide base gait in cerebellar disease, circumduction, hemiplegia, waddling gait, myopathy, high stepping, foot drop, stamping, sensory ataxia, magnetic gait, also known as apraxic gait. Apraxic gait is seen in NPH or normal pressure hydrocephalus. Okay, all right. Okay, just revise these tables. Okay, very high yielding. Now next question, again endocrinology question. Which of the following can be used in the management of a 28-year-old female diagnosed with prolactinoma who presents with amenorrhea and galactorrhea? Is it risperidone, chlorpromazine, alpha methyl dopa, or cabergoline? What do you think? Okay, so prolactinoma management, the pharmacological management is being asked. Okay, now see, whenever you are wanting to manage prolactinoma, you have got to think of dopamine agonist. Okay, now in this there is one dopamine agonist, and that is going to be option D. Very good. Aditya, Nishita, Pankaj, Harman, Neeraj, Gautam, the whole batch is rightly saying answer is cabergoline. Okay, all right. Now let me ask you one question. If it was pregnancy, what is the favored dopamine agonist? If it was pregnancy, what is the favored dopamine agonist? It is bromocriptine. Okay, now let me ask you one question. Out of the three options that are given, risperidone, chlorpromazine, and alpha methyl dopa, what do you think is common to all this? Risperidone, chlorpromazine, or alpha methyl dopa? What is the problem? Yes, Akram is right. Bromocriptine in pregnancy. Well, see, risperidone is what? It is an atypical antipsychotic. What is chlorpromazine? It is a typical antipsychotic. Alpha methyl dopa is there. Remember, all these drugs, well, they increase prolactin levels and should never ever be given. Forget about treatment. They should never ever be given in patients with prolactinoma because it will increase prolactin levels, even alpha methyl dopa. And you know the relation between dopamine and prolactin I have already covered in my lectures as well. Okay, all right. Next question. The following general examination findings were noticed in a 40-year-old male who presented to the OPD. What is the likely enzymatic defect? What do you think? What is the physical finding showing here? There is some blackish pigmentation involving the sclera and also your ear creases as well, earlobes as well. So blackish pigmentation, which biochemical disorder is associated? Well, this is associated with ochronosis, right? Ochronosis, which happens because of deficiency of an enzyme homogentisic acid oxidase. So homogentisic acid oxidase enzyme deficiency results in ochronosis. Okay, and one extra question I am asking for you all. So for ochronosis, what is the spine involvement? The spine involvement in ochronosis produces what? Spine involvement. Spine involvement. What is the radiological finding? What is the radiological finding? What is the spine involvement, radiologic finding? Let me see if anyone answers that. I'll just wait for your answers. Okay. All right. So let me go to the next question. I'll come back to this. Okay. And so the image is showing the endoscopic picture of a 73-year-old male who is admitted for evaluation of GI bleeding. What is the most likely diagnosis? Achalasia cardia, CA stomach, candidiasis, GAVE. What is it? So the endoscopic view, which is given in the image, is a famous one, a spotter one, a favorite one for your exam. This is called a watermelon stomach. This is called a watermelon stomach. And whenever you have a watermelon stomach, Satyaprakash has already given a picture of watermelon as well in the comment section. So you have got to think of this entity, that is gastric antral vascular ectasia. Okay, so GAVE. Okay, so the answer is going to be gastric antral vascular ectasia. Coming back to the previous question that I asked, none of you have said the right answer. So that is called a dagger spine. Okay, it is called a dagger spine. So ochronosis can involve the spine, and there is a calcification also. So that is called a dagger spine. Okay, dagger spine. Okay, all right. Next is again a pulmonology question. The following image shows the sputum study of a 45-year-old female admitted to the medicine ward with a chronic respiratory problem. So they have not mentioned what disease, but there is a chronic respiratory problem. What is the likely diagnosis? So what is the likely diagnosis? You see the sputum finding. So I'll just show you the finding here. You look at this finding and this finding in the form of spirals. What physical finding is, what examination finding is this? Kirschmann spirals. And presence of Kirschmann spirals in the sputum is suggestive of a diagnosis of bronchial asthma. What is the other sputum finding that you can see in bronchial asthma? Charcot-Leyden crystals. Charcot-Leyden crystals, you know their relation, no? They are related to eosinophils. Okay, all right. So this is clear. Next question, again from hematology. So this is regarding a case of a bone marrow failure syndrome. So a 16-year-old boy was referred to a tertiary hematology center as a case of bone marrow failure syndrome. The hematologist makes an observation of the following findings in image. What is the likely diagnosis? What do you think? What is the likely diagnosis? So you can see a set of three images. In the first one, you can see the patient is having significantly dystrophic nails. And second one, there is evidence of leukoplakia. Are you able to see here? Leukoplakia. And the third one, you are able to see, reticular skin pigmentation. Reticular skin pigmentation. Now you have got to identify the bone marrow failure syndrome associated with dystrophic nails, leukoplakia, reticular skin pigmentation. Is it pure red cell aplasia? No, it's not SLE. It's not chronic hepatitis C infection. This condition is known as disc keratosis congenita. Okay, this is known as disc keratosis congenita. Very important. Now, in majority of the exams, you are likely to have one question on acid-base balance. It might be a simple scenario to identify the acid-base disorder. Okay, so you might be given values, but here, I am just giving you a simple, straightforward question. So, in the DocTutorials app, I have detailedly given you how to come to a conclusion in simple acid-base disorders, like what is the deficit. Okay, so just go through that if you have not gone through it yet. So, a female with hysteria was hyperventilating, following which she developed carpopedal spasm. What is the acid-base abnormality? What do you think? So, whenever you have hyperventilation, what is the buffer that is eliminated? It is carbon dioxide. So, commonly when you hyperventilate, what often happens is a carbon dioxide washout. And in the acid-base lecture in DocTutorials, in the first video where I have told you about the basics of acid-base balance, I have started by telling you that carbon dioxide is like the acid in your body. So whenever you have carbon dioxide washout, it is going to be alkalosis. Okay, the acid is lost, it is alkalosis. And since it occurs because of a respiratory elimination, this is called a respiratory alkalosis. Now, why did the patient develop carpopedal spasm? Can somebody tell me why? Well, always remember, whenever there is a alkalosis, this will promote the binding of calcium to the albumin, which means the fraction of ionized calcium in the blood will come down. So, ionized calcium in the blood is coming down, because of which the patient may have features of what? Hypocalcemia. The patient may have features of hypocalcemia. Okay, and that is what actually leads on to manifestations like carpopedal spasm. So, what is going to be the answer? The answer is going to be respiratory alkalosis. Okay, respiratory alkalosis. Okay, all right. Okay, next question. 68-year-old male presented with unilateral ptosis with no other symptoms. Okay, just say unilateral ptosis, and on application of ice pack to his left eye improved his symptom. What is the diagnosis? Well, a patient presenting with a unilateral ptosis can have numerous possible etiologies. Okay, but there is one condition specifically where the ice pack improves the ptosis, and that condition is what is known as what? Myasthenia gravis. So, in case of myasthenia gravis, which is a problem with the neuromuscular junction, there can occur ptosis, but you apply the ice pack. Let me just show you a figure. See this patient with ptosis of the left eye. An ice pack, cold, is being applied to a closed eye, and for 2 minutes you are keeping like that. Then you remove it. You will see that the ptosis improves. This test is known as ice pack test. Ice pack test. And a positive ice pack test means the possibility of myasthenia gravis. Now tell me one thing. See, when you have this ice pack test, you tell me one thing. See, how does this improve the ptosis? The basic reason why it improves is that application of ice or cold improves neuromuscular transmission. Okay. Now let me ask you, a common question. So the common question I want to ask you is, if cold improves the neuromuscular transmission, is application of ice pack a treatment for myasthenia gravis? Is it a treatment? Yes or no? Is it a treatment? Yes or no? Yes or no? So answer is no. Why? Because this improvement in ptosis on application of ice pack is only very transient. So don't think that, okay, you just apply an ice pack, you can be the, the holy Baba, just applying the ice pack and patient improves. It's not like that. It's only a temporary improvement. Okay. Yes. So this is myasthenia gravis. Okay. All right. Next question is again a question on hematology. So the question goes like this. This is a 40-year-old man who is referred to a tertiary hospital with fatigue, anorexia and EC bruising. Lab evaluation HB8, TC 28,000, platelet 80,000. Given below is the image of a peripheral smear. What is the diagnosis? Okay, what is the diagnosis? See, it's very clear that the patient has presented with fatigue, anorexia and EC bruising. Okay, so there is anemia, clear. There is leukocytosis. There is thrombocytopenia. Okay, so this alone doesn't give us a concrete idea, but the peripheral smear specifically points to one particular cell. And now, dear students, you tell me what is this particular cell that is being pointed. Well, what is the cell? Pragya, excellent answer. Pragya Subedi, very good, excellent, good answer. So the cell that you are seeing is a myeloblast. Okay, but what is so peculiar in this myeloblast? Let me just show you a couple of arrows here. The arrow is pointing to a specific finding. So what is that specific finding that I am showing you? Well, this finding is known as, these rod shaped structures are known as OR rods. These are known as OR rods. And this OR rods, they are a feature of what? An important leukemia, that is AML, acute myeloid leukemia. And OR rods are mainly seen associated with the which subtype? Promyelocytic leukemia. So this is a patient, because he is having anemia, he is having a presentation with fatigue, but the peripheral smear is very important. This is how you link medicine and pathology, and I am sure that all you guys will pass the exam provided you stay cool, you have studied so well. Only thing is that on the day of the exam, have good presence of mind, stay happy, have a smile in your face and tell yourself, let me try to do my best. That's more important. So otherwise what will happen, you tend to make all these silly mistakes. Okay, that's when all these silly mistakes come. Otherwise I'm sure you will definitely cross the passing mark. Okay, so what is going to be the answer here? Acute myeloid leukemia. Okay, all right. Next question. This is regarding a chronic kidney disease patient. So here again is some sort of an integration between nephrology and cardiology. Chronic kidney disease patient brought to the emergency department, progressive breathlessness for the past 2 weeks. His urine output in the last 24 hours before hospital admission was approximately 300 ml. ECG taken in the emergency department is shown below. Which of the following drug should be given to the patient urgently? So what are the clinical data that we have here? So patient is already having a chronic kidney disease. He is having a presentation with breathlessness for past 2 weeks. Okay, breathlessness is there. So we are not sure why the breathlessness is there. So last 24 hours his urine output is 300 ml. And what do you call it? And what do you call it? You will call it what? Oliguria. Urine output less than 400 ml, you call it oliguria. So there is oliguria and EC. So there is some sort of a worsening of a chronic kidney disease. And I assume that the most common reason why the patient has breathlessness is a pulmonary edema. His kidney is not able to, excrete urine, he is having pulmonary edema. All right, but look at the ECG now. I'll give you 30 seconds to have a good look at the ECG and come out with your diagnosis, or maybe what treatment will you give. So the ECG, as Pragya is rightly saying in the comment section, is having some sort of a sinusoidal pattern. You can see the sinusoidal pattern here. Yes, a sinusoidal pattern. In the context, see, Hello. So just let me know if my voice is okay now. Okay, so I hope the video, audio, everything is fine now. Okay. Yes. All right. So, see, in this particular patient, a very simple straight look at the ECG might give you an impression that this is a probable, say, a ventricular tachycardia. But you have got to, yeah, thank you Raja Mahindran sir, thank you so much. So, but here in the setting of a chronic kidney disease, since the patient is not having any palpitation, otherwise hemodynamically stable, tell me which electrolyte abnormality will you think of in this patient? Which electrolyte abnormality? Yes, you have got to think of hyperkalemia. And why specifically hyperkalemia? Because see, whenever you have hyperkalemia, the ECG changes would progress in a particular fashion. As you all know, it begins with your peaking of your T waves. So you get peak T waves, but as the potassium level further increases, you get new changes like wide PR interval, wide QRS, peak T wave. Subsequently, in final stages, there is loss of P wave and a sinusoidal pattern. So what you are seeing here is a sinusoidal pattern, probably because of hyperkalemia. And whenever you are having hyperkalemia, tell me which drug are you going to give this patient? Hyperkalemia, you have got to stabilize the membrane, and the drug that has to be given as emergency is calcium gluconate. Okay, calcium gluconate. All right. Yes, so that is pretty clear. Okay. All right. Now, the next question, this is again a cardiology question. The following is the ECG finding of a patient. So, of a patient with acute onset breathlessness to the emergency. Okay. So, just it is given acute onset breathlessness. What is the confirmatory test for the diagnosis? Echo, chest X-ray, pulmonary function test, ventilation, perfusion, scanning. What do you think? Let me just give you a better view of the ECG. You've got to be careful here. Just have a good look at the ECG. What abnormality are you seeing here in this patient with acute onset breathlessness? Now look at the QRS morphology here. Okay, look at the QRS morphology. So I am putting some blue arrows and some red arrows. Are you seeing an alternate difference in the morphology of the QRS complexes? So you are seeing some of the QRS complexes of larger amplitude, which is alternating with QRS complex of small altitude. So what do you call this? Okay, so the amplitude is actually different, it is alternating, and this is called what? Electrical alternance. This is called electrical alternance. Now, ECG manifestation of electrical alternance is commonly associated with which condition? A cardiac tamponade. So when you have a pericardial effusion, a fluid in the pericardium, so in pericardial cavity, when you have cardiac tamponade and your, the heart swinging in this axis, it will have alteration in the QRS morphology because of the swinging of the heart within the fluid, which is called electrical alternance. But the question the examiner is asking, what is the confirmatory test? Now in your mind it should first strike, okay, this is probably a cardiac tamponade, and what is the investigation that you will do that will confirm the diagnosis is going to be a echo. So an echo is going to confirm the diagnosis. Okay, all right. Next question. The below chest X-ray is that of a 58-year-old chronic alcoholic who is admitted in the medicine ICU as a case of pneumonia. What is the likely organism? Is it Staphylococcus, Streptococcus, Klebsiella or Pseudomonas? Well, alcoholic pneumonia. So obviously in the X-ray when you look, you can see a large area of consolidation. So this is a lobar consolidation. But how unique is this lobar consolidation? It is unique in one aspect. You can see the fissure is actually bulging down. So this type of consolidation where you have a downward bulging of the fissure is called a bulging fissure sign. Is called a bulging fissure sign. Okay, is called a bulging fissure sign. Now tell me, there are two important clues in this question. One is it is a chronic alcoholic, second is a bulging fissure sign. Now which is the likely causative organism which is having a predilection especially for the upper lobe in the lobar consolidation? Chronic alcoholic with this bulging fissure sign is commonly associated with what? Klebsiella. So Klebsiella pneumoniae, it is commonly associated with this. And as Satya is rightly saying, the patient can have red currant jelly. Okay, red currant jelly sputum. Okay, all right, fine. Next question. This is just integrating medicine and physiology. The below is the diagrammatic representation of the breathing pattern of a patient admitted in the medicine ICU with acute onset breathlessness following a chest pain. What is the pattern of respiration here? Is it chain stalks, biots, ataxic pattern or the Kussmaul's? Now this is a common pattern of breathing we commonly see in the ICUs, and if you closely look at this pattern, it's very simple one. You can see it is a waxing and waning, and there is a pause in between, again a waxing and waning type. So what is this pattern that is known as? Excellent. Pragya, Neeraj, Niyas, no, Neeraj has said biot, not biot. So Neeraj, tell me, why is this not a biots breathing? I am saying the answer is chain stalks. So what is the main difference between a chain stalk breathing and biots breathing, the pattern wise? Can somebody answer in the comment section? Pattern wise, chain stalk, biots. Kussmaul breathing, commonly you can see in patients with diabetic ketoacidosis. Okay. Yes, so in biots breathing, so you are not going to get the typical waxing and waning nature. You will have that pause in between, but you are, or the period of, what do you call this pause? You will call it as a period of apnea. So in biots also that period of apnea will be there, but this typical waxing and waning will not be there. Okay, all right. Next question. From the general examination finding of this patient, a 40-year-old female admitted in the medicine ward, what likely nutrient deficiency is this patient having? Remember, I have told you already 1 or 2 questions will come from nutrient deficiency. So what is the finding? The first image is showing some sort of petechial hemorrhages are there, and a close-up view also shows these hemorrhages, especially around the hair follicles, and maybe at least some of you can appreciate some sort of a corkscrew hair. Okay, corkscrew hair. So what is this likely to be? And the third image is actually post treatment. Okay, the third image is post treatment where the patient has improved. But can you tell me What is the characteristic nutrient deficiency associated with perifollicular hemorrhages? Perifollicular hemorrhages and corkscrew hair. It is scurvy or vitamin C deficiency. Scurvy. Okay, very good. Very good. Pragya, very good. Good. I think majority of you people have already passed the exam. Okay, you're all answering wonderfully well. Let me see if you can answer this one. Correlating with anatomy. While performing a lumbar puncture, which of these layers is punctured the last? Okay, dura mater, pia mater, arachnoid and ligamentum flavum. Okay, which is punctured last? Let me see who gets this right. So the answer to this question is the arachnoid. Okay, because this can be asked either from an anatomy point of view, medicine point of view as a neurology question, or even from an anesthesia point of view also you can get this question. See, when you do a lumbar puncture, the layers which are pierced in order, one is skin, then subcutaneous tissue, the supraspinous ligament, interspinous ligament, ligamentum flavum, epidural space, dura, arachnoid, and then finally subarachnoid space it enters to. So this arachnoid is relatively pierced later. So which is why arachnoid is going to be the answer. Okay, very simple question. Okay, okay. Now, which of the following neurodegenerative conditions associated with chorea most likely causes the pathological findings seen in the figure? So I am trying to correlate medicine with pathology here. So is it Alzheimer's disease, frontotemporal dementia, normal pressure hydrocephalus, or Huntington disease? What do you think is the answer? What do you think is the answer? So what do you think is the answer? Well, as you can very well see here, what gross finding is striking you? What gross finding is striking you? What gross finding is striking you? Let me see if you are able to answer. So, yes, as Nishita and Niyas, you have rightly said, excellent answer. Very good observation you have, because I thought many of you would say some atrophy of the brain. But what is very striking here is the atrophy of the region which I am pointing here. What is that region? It is the caudate nucleus. So here the gross finding is that of a caudate atrophy, and because of which the ventricles are slightly widened. So there is atrophy of the caudate nucleus. Well, even if you cannot appreciate much of the gross here, the common condition that you have associated with chorea, one is Sydenham chorea and the second is going to be Huntington disease. You can answer in that logic itself. But let's try to understand here a comparison between normal brain and a Huntington disease. You can see that normally this region, you have the region of, this is the caudate nucleus, this is the putamen. In patients with Huntington disease, there will be atrophy of the caudate nucleus and putamen. It's a disorder that affects the basal ganglia. So there will be an enlargement of the ventricle. So which is why what is going to be the answer? Huntington disease is going to be the answer. Okay, all right. Okay, next is again a cardiology question. The following pulse tracing is most likely seen in a patient with, is it severe AR, severe AS, mild AS or mitral stenosis? What is the pulse tracing that is shown? What do you think? Pulse tracing. Well, the pulse tracing, you can see it being correlated with the heart sound. So S1 is the first heart sound, A2, P2 are components of the second heart sound. So this particularly you can call it the duration of systole. Okay, so in this pulse tracing, definitely it's abnormal. And what is the abnormality that you are seeing is that there are two peaks in systole. So there are two peaks in systole. So there are two peaks in systole. And what do you call a pulse tracing with two peaks in systole? It is called as a bispheriens pulse. Okay, it is called as a bispheriens pulse. Now tell me, bispheriens pulse is commonly associated with which condition? It is commonly associated with a severe aortic regurgitation. It is associated, Pragya, absolutely right, bispheriens pulse. Okay, all right. So next question. Again a long question, again a question from endocrinology. This is regarding a 30-year-old pregnant female who developed severe postpartum hemorrhage and then developed palpitation and dizziness. Patient went into hypotensive shock, refractory to fluid resuscitation. On examination, she had cold, clammy extremities, heart rate, tachycardia, hypotension was there. What is the most important step in the management? Now, after a postpartum hemorrhage, patient developing hypotensive shock, what is that you will think of in this patient? Can somebody tell me what will you think of in this patient? Well, remember, in case of a postpartum hemorrhage, a common accompaniment is that of a postpartum pituitary necrosis, which is called a Sheehan's syndrome. Which is called what? It is called a Sheehan's syndrome. Okay, Sheehan's syndrome, as Niyas is rightly saying. So this is a case of a Sheehan's syndrome. So Sheehan's syndrome is the answer. And how will you manage a case of Sheehan's syndrome? So Sheehan's syndrome, the most immediate step in the management will be hydrocortisone. Does that mean that other hormone supplementation is not to be given? No, even other hormone supplementation has to be given, but on priority as a life saving in Sheehan's syndrome as well as in condition like pituitary apoplexy, you have got to give the patient hydrocortisone. Okay, so the answer is going to be hydrocortisone. Okay, yeah, all right. Let's go to the next question. Now, the 73-year-old diabetic hypertensive male, it's a question from neurology, noted a sudden onset difficulty in moving his left upper and lower limb. Note the time here in the question, very important, at 6 p.m. today. Okay, so 6 p.m. left upper limb, lower limb weakness. Presented to the emergency department at 10:40 p.m. BP 150/88, conscious oriented, had dysarthria, left UMN facial palsy and grade 0 power of left upper limb and lower limb. CT brain showed a right MCA infarct and CT angio showed a right proximal M1 occlusion. What is the next line of management? What do you think? What is the next line of management? What is the next line of management? So Anjali is saying lower BP with labetalol. Nishita is also saying lower Neeraj. So majority are going for A. Majority are going for A. Is it A? Okay, so some are saying B. So is it a toss between A and B? Well, I'll tell you. See, whenever, let's keep it very simple. In the next 2 minutes, I'm going to simplify acute management for you. Patient presenting with acute stroke. If the patient presents in less than 4.5 hours, you can go for IV thrombolysis. Okay, IV thrombolysis. if the patient presents in less than 6 hours and has proximal large vessel occlusion, which means the middle cerebral artery will have a proximal part and a distal part. If there is an occlusion involving proximal part, then you can go for mechanical thrombectomy. Okay, mechanical thrombectomy. Okay. So here tell me, can you thrombolize? Can you thrombolize here? You can, those who have said the answer as B, patient symptoms started at 6 p.m. 10:40 p.m. now. Patient presented to the emergency. So already 4.5 hours over. Correct, no? 4 hours 40 minutes over. Can you thrombolize? Can you thrombolize? You cannot thrombolize. But what is the imaging showing? He is having a proximal M1 occlusion. So it's only 4 hours 48 minutes. So what you can do here, tell me dear children, in a patient who has presented within 4.4 hours, 4.40 hours, okay, 4 hours 40 minutes, okay, 4 hours 40 minutes. You cannot go for thrombolysis, but you can go for what? Mechanical thrombectomy. So your answer is going to be option D, mechanical thrombectomy, where you are going to remove the clot. Okay, so it is an endovascular procedure. You go through either your femoral artery or radial artery through an endovascular procedure. With the help of a stent retriever, you are retrieving the clot, removing the clot. In my lectures, I have shown you the image also how it is being done. You remove the blood clot. So the answer is going to be mechanical thrombectomy. Now one additional point, let me, if you ask me, sir, patient presents within 3 hours and he is also having a large vessel occlusion. Then what will you do? Will you do thrombolysis or mechanical thrombectomy? Remember, you will do first thrombolysis followed by, you have to do both, thrombolysis followed by thrombectomy. Thrombolysis followed by thrombectomy. You might ask me another question, sir, why you are specifically saying proximal large vessel occlusion? Why don't you go for mechanical thrombectomy in distal large vessel occlusion? Problem is, only large clots you will be able to take by this, stent retriever device. Okay, small, clot you cannot actually take it. So it is so much distal circulation. So you have to consider risk versus benefit. Don't think it is a very easy procedure doing the endovascular mechanical thrombectomy. So you have got to be careful. So what you have got to do is you have got to select the appropriate patient. So in a patient with a proximal occlusion, you can go for a mechanical thrombectomy. Now, see, I saw some people, answering as lower BP with labetalol. See, for a BP of 150/88, I have already taught you in my lectures, even if you are planning thrombolysis, what is the BP cutoff? You are going for 185, no? 185, 110. So you need not actually lower the BP here. Remember, too aggressive reduction of BP in a stroke patient is deleterious, because at the time of a stroke, when your brain is not getting enough blood supply, it is your cerebral perfusion pressure that maintains the perfusion. And if you abruptly lower the BP, your perfusion will be further affected and your infarct will increase in size. So you should not do that. Okay? All right. So I hope you are clear with that. Okay? Yes. All right. So the answer to this is mechanical thrombectomy. Most common mutation found in MODI. What is MODI? It's not Narendra Modi. It is maturity onset diabetes of the young. What is the most common? It's a factual question. So I know that in majority the questions today were clinical scenario question, but you can expect factual questions. This is an important topic, maturity onset diabetes of the young. So here, see, the answer to this question is HNF1 alpha. The most common MODI is MODI 3, and I'm just giving you the list of the MODY type and the gene mutated. MODY3 is HNF1 alpha, and that is what is being asked in this question. Okay, all right. Next question, 20-year-old boy present. It's a hematology question. Okay, I hope all of you are with me. Just just a few more questions and we'll be done. But I hope all of you are with me. Yes or no? Let me know. So this is regarding a 20-year-old boy who presented with a fever of 1 month, gum bleeds and EC bruisability. Examination showed petechial rashes. On evaluation, HB is 5. Okay, total WBC count 1500, platelet count 15,000. Peripheral smear shows macrocytes. Bone marrow examination showed fatty streaks, absent megakaryocytes and no immature cells. Now it's very, very straightforward from the question that it is a scenario of a pancytopenia because HB is reduced, WBC is reduced, platelet is reduced, and all symptoms are because of the pancytopenia. Okay. Now what is the bone marrow showing? Well, bone marrow is showing fatty streaks. Fatty streaks is what the bone marrow is showing. Now bone marrow showing fatty streaks is a very important finding in case of aplastic anemia. So you see this, a comparison of your normal marrow and this is a aplastic anemia. This is a low power view and this is a high power view of aplastic anemia. This is straight taken from your Robbins textbook. So you can see so much of fat. So the marrow which should normally have lot of hematopoietic cells is replaced by fat. Which condition does this happen? It happens in aplastic anemia. Aplastic anemia. So this is called a idiopathic aplastic anemia. Okay, all right. Now the last question for the day. It's a calculation, and this question was once asked in NEET PG as well. Let me see how many of you give me the answer for the last question of the day. Okay, so those who are answering this, let me see. 30-year-old male weighing 70 kilogram has a serum sodium of 120 milliequivalents per liter. What is the sodium deficit? 280 milliequivalents, 480 milliequivalents, 840 milliequivalents, 1400 milliequivalents. What do you think is the answer? Okay, what do you think is the answer? It's a formula. You have got to know the formula to answer this correctly. Okay, yes. We doctors are very poor in mathematics, so I expect a slight delay for the answer, but let me just wait for you. It's the last question, but a very important question. Okay, though it is the last question, it's a very important question. So I see so many option B, C. Okay. See, this is a very important question, and if you do not know the formula, you will not be able to answer. See the question, what is it regarding? It is regarding the sodium deficit. So remember, the calculation of sodium deficit goes by this formula. One is the percentage of body weight, body water, total body water percentage into weight in kilogram into the difference between desired sodium and actual sodium. Repeat it with me. Total body water percentage into weight in kilogram into the difference between serum sodium and actual sodium. Now the first one, that is the total body water percentage, for men the value is 0.6 and for female the value is 0.5. Okay, 0.6 and 0.5. Now let's come to this question. So here it is regarding what? Male or female? Male. Serum sodium is 120. Now guys, you tell me what is the normal value of serum sodium. It comes to around 136 to 145. For an average, let's take 140. Okay, 140 for an average. So the current serum sodium is 120. Desired serum sodium is 140. So 0.6 into weight in kg is 70 into desired sodium 140, actual sodium 120 into 20. Okay, what is this going to be? What is going to be? What is it going to be? Answer is going to be 840. Okay, answer is going to be 840. Okay, so 840 milliequivalents is the answer. Okay, so that is the sodium deficit. Okay, all right. So that's it for today's session. We have had a detailed discussion of the most important questions. The most important questions we have discussed. Okay, it is covered. I hope the session was useful for you, beneficial for you, useful as a last minute revision. Neeraj, see, already it is 11 o'clock and we have taken 3 hours. So I have exceeded the time limit also of the 2 hours. So, whatever important points you want, I'll do one thing, I'll share in my Telegram group. Okay. So let me just share my contact number. This is my contact number, Telegram number and WhatsApp number. Okay, Telegram number and WhatsApp number, and I'll add you. So Disha is asking, could you discuss more ECG related questions? Definitely yes. In my Telegram group I will discuss the questions for sure. And yes, so you just let me know if you, in the coming days, if you want me to post some important MCQ on any specific topic, I will definitely do it. And I think let's share the DocTutorials Telegram group and also my Telegram group link also. We'll share the 2 links now. Okay, I'll just ask the staff to share the link of the DocTutorials Telegram group as well as my Telegram group. Now, before I end, 2 minutes, just 2 minutes, give me 2 more minutes to tell you my suggestions, last minute suggestions leading on to the exam. First thing is, never underestimate yourself. You might feel, sir, I am weak in PSM, sir, or I am weak in microbiology. See, to pass this exam, you need not be a master. You need not be a master in all subjects. Okay? To get the passing, you need not be a master in all subjects. So forget that. You have studied well over the last several months. You have studied your notes. You have revised it. You have asked your doubts to your teachers. You have practiced MCQs. That's enough. Now, don't go for too many tough MCQs at this point, because it will only demoralize you. Stay contented with what you have and what you have prepared. That's enough. It will definitely make you pass. And when you go to the exam hall, I want to tell you one thing. Knowledge level is important, no doubt. Knowledge is important. But important is your presence of mind. I'll tell you, I always tell this to my students. What often matters in the exam is presence of mind. Because see, when you are having multiple questions, you are answering multiple questions. Like one PSM question, one medicine question, one surgery question. Focus has to be good. For example, if I am answering question number 48, okay, maybe question number 46 was tough for me, 47 I had no clue. But when you are answering 48th question, just think of the 48th question. Don't think of question number 47 or 49. Your focus should be only on the question on screen. What often happens is you tend to develop a panic. Okay, I don't know question 47, what will happen, this exam is not going my way. Then what happens is, actually question number 49 might be a very simple question, but because you are so anxious, you will get it wrong. Okay, so you can just note in the comment section, the staff has put the Telegram link of my Telegram group as well as the DocTutorials Telegram group as well. Please do join that. So what I am saying is, just focus on the question. And remember, when you write a long exam, at least some of you have even personally messaged me also, sir, when I start writing the initial 50 questions, okay, it is going good. But after that, my concentration goes. Now this is also very tricky, because remember, I say this to all my students before the exam. The success of a student in writing an MCQ exam, a long MCQ exam, is attending the first question and the last question with the same energy level. With the same energy level, the same passion, the same determination. That's more important. Okay, so that's what I want to tell you. I don't want to give you too many advices. Presence of mind, one question at a time. Self-confidence, never underestimate yourself. You will definitely pass the exam. Okay, but just keep believing in your abilities and tell yourself, I'm going to do it. I'm going to make my parents proud, my teachers proud. And definitely, it was great to interact with you. And do let me know after your exams also, your results, because see, we are all health professionals. We would like to stay in touch. In the long run, we might meet in various conferences. So definitely we'll have a cup of coffee then. So stay tuned to DocTutorials. In the Telegram groups, we'll be sharing more academic updates as well. All right. So it's a best of luck from my side. And thank you everyone. Bye-bye. Take care. Good night.